Good morning. Yes, morning everyone. So as introduced, my name is Stella Zawedde Muyanja, and I'm a current doctoral scholar with the IDI HIV co-infections D43 grant. I will take you through my journey as a researcher. I might be the oldest scholar here, so it's going to take a while to get through this. But you know that people say it takes a village to raise a child. In my case, I think it was the whole sub-county. as you can see, because I started off as a medical officer, trained in Mbarara University of Science and Technology. I then went on to Mukono District, where I was immediately put in charge of a health center 4 and a health sub-district. And I had to learn health programming from scratch. Didn't know anything about it. Came straight off the ward, right into a health center 4. And the biggest challenge when I was there was that our TB completion rates were 46%, which even in the pre-art era was really dismal. So I had to take charge of the TB clinic and learn, how to do implementation, how to do programming, how to make more people complete their treatment. I had a lot of help from the district leprosy program officer and a lot of help from my DHO. And I'm glad to say by the time I left 3 years later, we had a completion rate of 66, which isn't very, but in the pre-art era, it was quite something. And while there, I got some training from HIV, from IDI in HIV management for doctors, which then pushed me sort of into the research angle, because I had all this new knowledge that was so exciting, so new, and I felt I needed somewhere to use it. So I then moved to the Medical Research Council, where I was a medical officer on the Entebbe cohort, and that was a cohort of HIV positive patients, and we were following them up and trying out different interventions on them. While there, I got training in research methods. That was my first training at University of Leeds, sponsored by the MRC. And I got that training, in data analysis, and I was really excited about it. Took it and did my first publication, which was Trends of Bacteremia in HIV-positive patients over an 8-year period before and after ART. From there, I won an EDC TP scholarship to do a Masters of Public Health here in Makerere. And during that time, I then moved into the IDI, which was quite exciting because I had encountered IDI in 2004 as a trainee, and I promised myself I would come back. I would find a way to come back. So then I came back and I was a trainee in the Masters of Public Health, and I was really excited about my work. And there, and then after about 2 years, I moved on to the union. But while in between, my first encounter with NIH funding started. I got a Global Health Fellowship, which was training people who were dealing with programming and teaching them how to use program data, to analyze it, and how to use it to better service delivery. So that NIH grant was called the Afiabora Global Health Fellowship, which I did for 1 year, and which taught me two main things. It taught me grant writing, because we had a very extensive module on grant writing during that fellowship, and also the use of programmatic data. And I took that knowledge and I did 3 publications, all first author, simply looking at programmatic data and analyzing it and seeing how we could use it to impact programming. Then, and that is, also I took the training on grant writing and wrote my first small grant, which was really small, 50K, but it was my first one. And then in 2016, through IDI again, I got the doctoral scholarship. That doctoral scholarship, my doctoral work is focused on improving linkage to treatment for patients diagnosed with TB, and it's embedded within the Xpert TB study. So just a brief about my work. My research topic is improving linkage to treatment among patients diagnosed with Xpert testing in public health facilities in Uganda. the study utility, the reason we're doing this study is we are trying to address some of the gaps Uganda faces in reaching the first 90 for TB. So the first 90 WHO mark is to start at least 90% of incident cases on appropriate TB therapy, whether that is MDR TB or drug-susceptible TB. And currently, Uganda is at 62% for drug-susceptible TB and about 50% for MDR TB. And through part of my work analyzing routinely collected data that I mentioned before, we found that about between 25 and 40%, depending on where you look, of patients diagnosed with TB never start on TB treatment. So this is an area where people have come to the health facility, they've gone through the diagnostics, but we are losing them before we start them on treatment. And so we came up with my mentor, Dr. Katamba and Dr. Barbara. We wrote a study, which is a mixed method study, to characterize which patients are not linked to TB treatment, to elicit the barriers and facilitators for non-linkage to treatment, and 3, to develop an intervention that addresses the elicited barriers for non-linkage to treatment. So the main results of this study, and I have only one slide, but I'll talk through it. So we've collected data from about 10 health facilities and from across the range of care, so regional referral hospitals, district hospitals, primary care units. And we found that at least 20% of all patients diagnosed with TB are not started on TB treatment. And patients who are HIV positive, patients who are diagnosed at high volume health facilities, and patients without recorded phone numbers are most likely not to get linked to TB treatment. And when we interviewed both the patients and the healthcare workers to elicit the barriers, what we found in the health system was that they had extremely long turnaround times for TB tests. Mainly Xpert had turnaround times ranging from 24 to 96 hours. And so patients sometimes kept on coming back for their results, and those results were not ready, and then they didn't come back again. Then we also had improper recording of patient data on the patient forms, and a lack of patient education on the TB diagnostic process. So patients didn't know where to go back for the results, when to come back for the results, and there was a lack of communication. And for the patients, still long turnaround times for TB tests were a problem, lack of transport fares to come back for results for some patients, and a difficult health system navigation. So we are now at the stage where we are forming interventions, and our main intervention, because it came up for both patients and healthcare workers, is to reduce results turnaround time. We are aiming at same-day diagnosis, especially for high-risk groups. So especially for patients who do not have a phone number, so you won't be able to call them back if you lose them, patients who are HIV positive, and patients who come from faraway places and are likely to have transport problems. So we are making a triage system we are using Ginger Regional Referral Hospital as a case study, which picks out those patients and prioritizes them for same-day diagnosis so that they can start on TB treatment on the very same day. And then we are improving our recording on patient locators by making proper laboratory request forms. So in the OPD, they were using different forms which are not the standard Xpert forms, but also on the standard Xpert forms, there's not enough patient locator data. So we are borrowing from the HIV clinic because they have a patient locator form, and we are fusing it with our Gene Xpert form, and we are piloting that in our OPD and to make sure that we have enough patient locators. And then we are also working with the healthcare workers and the patients to standardize patient education messaging so that we tell patients to wait for their results, because what happened is that patients were leaving, they were being told go and come back later, and then they come back and their results are not, they are not present, or they would say go, we'll call you. then you find a patient who hasn't been on treatment for 6 weeks and said, they said they'd call me, so I'm waiting for that call. So we are changing that, and we are standardizing patient education to say it's important to get your result, please wait for your result. Yes, so those are the 3 interventions we are doing, and we are starting we've been, this month in September, we've been through a process of stakeholder engagement and focus group discussions and seeing what's going to work and what's not going to work, and then we'll start piloting this next month. So,
thank you very much.